but today I want to focus on prevention. And what we've kind of come down to is really management and preventative activities. What are these rowers doing that may incite rib fracture, and start to address them early? I think some of the things that we'll talk about, I'd love to see start with juniors. I think if there's certain principles that we can default to as far as their upper body function at that level, that will carry on to college, hopefully being reinforced there, and then we see that at the elite level, okay? So really the way to start, how do we start to teach them how to move, not just what their erg score is? Okay, what are they doing? Okay, how are they moving the boat themselves and the erg handle and not just focus on what their erg score is? Because I think the longevity of the athlete depends on that performance also, not on just how hard they pull. Okay, so really how they do it, and then can they be effective not only in their early stages, but then later on in their career if they have potential, and to avoid breaking down and create problems that can last throughout their career. What I'm providing also, if you go online, there'll be like a 7 or 8 stage program of exercises that each stage, I'll go over that, it'll just be kind of what you can work on, and everything's displayed in reps and things of that nature. So I put together like a 7 or 8 stage program. It starts from the beginning. If even with juniors you get through the first 3 and get certain concepts down, that's fine. I put things in later for higher end athletes, or if they're getting that, and how do you go through all this? And then once you're through this, will that help to, one, facilitate good function of the upper body and the upper quarter, get their core strength in with their upper body function, and give them the endurance and strength that they need to perform their sport without breaking down. Okay, and over time, what I found is that if they could get through what I've probably provided here, you shouldn't have any problems, okay? So really take it by stage. Really, if you can perform everything well, it's all based on form and meticulous movement. If you can perform that well at one stage, move on to the next, okay? And that's really taking it in that regard, all right? Not just rushing through things. And you'll see when we get to just film just how meticulous the athlete is who's performing this. And really, that's probably the speed that you need to work at. Okay. So as Dr. Wenker mentioned, it's really, what we found for rib stress injuries is that prevention, just consistent management of the shoulder complex, thoracic spine, lumbar spine, and hip, as well as the abdominal musculature. What you'll find is that all these areas connect into the rib cage. Rib cage is huge. It's an attachment site for major muscle groups, and all these areas can affect how the rib cage performs. Okay, so what we do with the national team is really manage upper body and lower body. All right, they're working at a level where we see them once a week for both their upper and lower body for the most part. If it's a collegiate athlete, probably like once a week for upper, another week for lower, they'll be fine. Okay, juniors probably can extend that out a little bit more. Okay, unless there's a problem. So really staying on top of things is really important, and also too, it provides an objective interpretation of their body that the athlete probably puts aside. Okay, you're trained to put pain away and not to deal with it. And it gives them an objective viewpoint that, whoa, this muscle's really tight. When I poke here, that starts to really hurt. What's going on here? And it starts the dialogue going. So good interaction with your medical team is great. Second best treatment is early reporting and prevention. How do we train these athletes to speak up? It's big. Okay, it bucks their system, it bucks what they want to do, but I know at the collegiate, junior, and the elite levels that we've trained them to kind of go talk to us. If we get to it early, we can prevent fracture, we can prevent things from happening, shut you down for a short period of time, maybe down cross-training 2 to 3 days is much better than being out for 6 to 8 weeks once you've had the injury. Once they get a grip of that, once one of their teammates gets a grip of that, they're on board, okay? They see one person failing out, they're in, all right? I think the biggest responsibility really is really looking at this as a isosceles triangle, each portion being just as important as the last one. The medical staff really being a liaison for the athlete and coaches, understanding pathology, what's going on, expressing to them how this is going to work, and that everybody understands what's going on. Coach has to let us know what the parameters are, what time of season, what's happening, and that medical person better be involved in that to understand how to get this athlete and treat them optimally for the time of year, racing, things like that. What's the best for the athlete and how fast can we do this? Okay, so everybody needs to know what's going on. The more interaction that's present, the better off it is. With the national team, I send a daily Google Doc. They have real-time information on every athlete that I see that day. So it's really important to keep that communication going. Also, too, is have an understanding that the athlete isn't going to dictate back to the coach what you told them. Okay, they're going to perceive it a certain way. You need to make sure everybody understands, or I need to make sure as a medical personnel that everybody understands what's happening at one level. And that can then change a training plan for that person or take them out, put somebody else in, or gives the coach time to make adjustments, gives the athletes time to heal, gets everything going optimally and back as soon as possible. Okay. Just sheer principles. If you remember anything about today, remember these things. Do not assume. Do not assume that you know what's going on, okay? I don't assume, and I'm a clinician. I've seen hundreds of these things, and I want to know. So that's where I bring in Dr. Wenger, or we'll do ultrasounds, or also, too, if I have a suspicion of something, I do not assume. We're going to look at the situation, get as much information as possible. That relieves the athlete, the coach, and ourselves so that we can guide treatment appropriately. If all rib stress fractures were treated as if all rib injuries treated as rib stress fractures, there would be a lot less rib stress fractures. Therefore, as soon as the rib cage is involved, the process of rib injury is occurring already. If there's spasm around the rib cage, this is a protective mechanism. There is some damage along the line. We have to determine whether it's bone and muscle, is the periosteal tissue involved that's around the bone, or is it just muscle or what have you. So as soon as that's on, the athlete has probably told you later than they need to, you just stop. Okay, 3 days rest, figure out what's going on, cross-train to capability without pain, and then let's find out, what's happening. So that's like a good just rule of thumb, okay? If there's nothing happening and you've checked that out, we do ultrasound, we'll know in 5 to 10 minutes exactly what's going on. So if if that's not capable, find somebody who possibly is, or use the medical system that you have, but encourage having things that are timely and speedy because that saves the athletes. So again, rest early. This is a big thing. Rehabilitate completely before returning to sport. Okay, this is one major area. How long have you had pain? A year, year and a half, and it never goes away. They never take care of it fully. And it becomes a recurrent problem, and in that recurrency, they change their biomechanics, and now you've got different things going on. All of a sudden, there's a pain here, there's a pain there. Sometimes this bothers me. Oh, that went away. And it's they're protecting themselves and now changing their mechanics. The longer you wait, the harder it is to get that back. Okay, so really getting that before returning to sport takes time. This is why prevention's huge. Okay, once you're in the process, it takes time. That's a fact. That's it. Nobody likes to hear it, the athlete, the coach, or even the medical personnel. And also to get really respect, if you have respect to the people that you work with, to respect medical clearance. Kid, don't go in just yet. It's not fixed yet. We put a Band-Aid on. This might change due to time of year and racing and things of that nature, but for the most part, everybody's got to work together and to keep that kind of consistency. Okay. What is the rib cage? All right. So this rib cage is this huge framework. All right, to which, its main thing is protection of the heart and lungs, Okay, so this thing is highly innervated, all the tissues around it. It's very dense in material that we'll see, and it's just meant to protect everything. That means you invade those ribs, they are going to shut you down, okay? It hurts. There's a lot of nerve tissue all through here, and also, too, that, you know, this is per individual rib, it's kind of weak, but as a unit, this thing is very strong. Okay, so it has to be, it provides support for a huge amount of muscle. All right, everything from the pelvis to the shoulder blade, all the abdominal muscles, all that diaphragm, huge amount of muscle for support. All those things affect the ribs. Okay. It's just amazing how much it involves. And then the other major thing is respiration, and why breathing, appropriate breathing with exercise is so important, because it affects the rib cage. Okay, that affects how it's going to function and work. Okay, so if you consider the rib cage, it's really, you know, I love the term Dave O'Neill has, two things that are never have enough of: love and bend in the oar. And the same thing that occurs with the ribs. You got to love them, and you got to make sure that there's bend in those ribs, that they can move, they're mobile, their tissues are supple around them and working well. All right, pretty much the rib cage, you can look at it as a long skull boat with 10 oarsmen. It needs to be flexible, accommodate all body positions, mobile. It affects the shoulder, scapula, spine, pelvis, and abdomen. Okay, it is made to absorb shock and external forces through all these muscles. All right, again, weak individually, but strong as a unit. Okay, if you had a boat with eight scullers, and two to three of those scullers were not moving, that boat would not do well. There'd be a lot of compensation of other areas to make up for those two or three paddlers that are not doing anything. Well, the rib cage is exactly the same way. You get two or three ribs that are not functioning well, everybody's got to make up for it. You also, too, increase the rigidity through injury. The tissues bind down. It is not a flexible, mobile area anymore, and now it's a branch that can break but not bend. Okay, so just, you know, it's kind of an analogy to keep in mind. The ribs move differently. The top ribs go up and down, lower ribs go in and out, okay? At that transition point, through the 5th, 7th rib is where we see most of the fractures, okay? T5 to 7, it's like 90% of them come right from there, okay? And again, if we look at the structures deep down, you can see the neck musculature elevates the top ribs. Pec minor really goes from the 3rd to the 5th rib. Abdominal muscles, huge, and they pull these ribs down. The other smaller muscles pull them up, okay? A lot of tissue in between, as well as nerve structures. Okay, so any inhibition, if you have an injury or a break to one rib, it binds itself to the rib above and the rib below. That means one injury to one rib shuts 3 down. Okay, it's like if you broke your finger, you would bind it to the next finger to stabilize it. That's what the body does through inflammation and scar tissue. Okay, and that can last forever. I've had people who broke their ribs 20 years ago. You go into the tissue between the ribs, it's still just as restricted. Okay, motion did not restore that. It needs to be mechanically done. Okay, so inhalation, again, lifts the rib cage, diaphragm, neck muscles, pec minor, all the, certain intercostal muscles do that. Exhalation, muscles in the front of the chest, intercostals, and the abdominals. All right, abdominals are huge, and we'll go into that, what happens with certain positions in rowing that affect that. Two main forces are the serratus anterior and the oblique abdominals, all right? One pulls down, one pulls up. The abdominals, if you're going way into layback, those abdominals are holding your entire chest wall up, okay? And not letting you fall back. In the same moment, the serratus anterior, as you're pulling, is trying to keep the shoulder blade onto the rib cage. And they pull in different directions, and right at this juncture is where 99% of rib fractures occur. Okay? Particularly right down below. And typically, both of these areas are tight in rowers. due to their posture and position. The scapula gets tight in the serratus with them coming forward. They're scrunched all the time. Their abdominals are tight, okay? So you add tightness, immobility onto these opposing forces. The rib moves like a paper clip, and boom, over time it starts to break down. Okay, so just kind of understanding that when you're looking at your strokes and things of that nature. And again, the abdominals go all the way up to the 5th rib. So that's the nipple line. Okay, so when you get these forces coming hugely from the abdominals, the external obliques, internal obliques that create torque and support, all right, they're taking on these little muscles in between the ribs, and it starts to torque the rib. Okay, a lot of the abdominal strains occur way up in the chest, and that could be not in the front, not be a rib. It's not a direct rib injury, but it's a strain of the abdominal. If that keeps going, they're going to get away from that, do some different torquey type motions, and now you can get the rib injury following that. Okay, so again, inhalation, breathing is important. It's going to lift the chest cavity with breathing in, okay? Exhaling is going to lower it back down and pull. So all the muscles up top are, when you're pulling, they're going to pull that rib cage up. Abdominals are pulling downward. Okay, if you want to, just going back, when you're sitting, those ribs move less. So if you put your hands on your own rib cage and you sit up tall and take a nice deep breath in, you can feel that excursion coming out to the sides, blow out fully, and you feel that move. Now I want you just to lean forward a bit and now try it again, and what you find is that the ribs do not move that much, okay? When you now move forward and you're sweeping and you go to one side and bend, the inside ribs do not move at all, and most of it's coming from the outside. So, understanding that their position restricts and changes their mechanism of breathing, and using corrective measures to help that post-exercise or post-training is very helpful. But just that sitting position alone changes the function of the rib cage. Therefore, what I like to do is really train them in belly breathing. Okay, and you'll see here, simple technique, just hands on the belly, okay, and just train them. Sometimes I'll put a 5-pound plate on their belly and have them just move it, and just really getting that abdomen to move rather than the rib cage. And what you see up in here is that this is quiet. Their neck and shoulders are quiet. Their forces are going downward when they exhale into the hips where it belongs. When they go into chest breathing, massive amount of pressure is going to happen if they're pulling and you have your lungs inflated and it's coming from the top. Also, too, the neck is tight and you're driving all the forces upward instead of downward as with belly breathing. Okay, so just how they breathe can affect how they function. Okay. So again, with belly breathing, ribs and thoracic cage remain relaxed, pliable, mobile, maintains and drives effort into the abdominal cavity and the pelvis, which is where you want it, supports the lower body stability for the lumbar spine, pelvis, and hips so they can drive the boat, okay? If you're chest breathing, tightens the neck, shoulder, and rib muscles, okay, maintains and drives effort into the chest cavity and shoulders, going into pulling up, increase rib bone compression with external forces like the oar, and facilitates stability and rigidity of the upper body, where we want that relaxed and mobile, okay? And then, again, limited intake with sitting, okay? It changes how you function. So belly breathing is definitely optimal. Posture, just like the doc talked about, I'm going to develop this wall of shame where it's really, there's a couch in the room, and I just look over and I'm like, stop, get out of that position. They're laying, all over the place, slumped over. And so I caught this guy, Anthony, and I'm looking at this like, talk about computer age. Now, he had, some low back and some rib issues. If I'm trying to increase the mobility of the front of his chest and hips and neck, and strengthen the back of him, that's not happening if he's doing this, 3-4 hours a day, okay? Just get out of that. Give them options. I take away seats, sit on a ball. If you get tired, you fall down. It's like pretty simple, So using things to help you maintain posture, educating them how to sit is huge. All right, I just get them on them all the time. They come in and they fear me because I'll just take a look at them now and they're back in business. So muscles, many muscles are affected by the rib cage function, position, mobility. If you're looking at rowing, just realize if you have tight calves and can't compress at the foot plate, the body's going to have to start coming over to get to the catch. If the hamstrings are too tight, when you get to the finish, body's going to roll over. You're not going to be in a great position at the finish. If the glutes are too tight, same thing as tight calves, you're going to make up for that by falling forward more. And that, again, attenuates the muscles in the back of the shoulder and the trunk, makes them weaker over time, and is not a good position for stability. So rib cage is affected by so many things. We just look at the outside. Again, we talk about the serratus and the abdominals. Look at the difference in size, just in sheer size of these muscles, and who's going to win. The abdominals are going to win. And, they're moving in opposing directions. Another big one is the neck, okay? The shoulder blade is like a truss. Okay, now you have the head is like a span, and the shoulder blades come off of the span from the neck. If the upper traps and the scalenes are too tight, okay, and the sternocleidomastoid, they elevate the shoulder blades and also the first rib. So you get people walking around like this. The doc talked about the old lady at the computer. You get rowers that can't descend the shoulder. So if you have someone, it's like, get that shoulder down, get that shoulder down, get that shoulder down. A lot of times they can't get the shoulder down. They need help to learn how to restore normal motion. Then you can get the shoulder down. I had one athlete, she was great because Cam's here, and he was training her, and he's yelling at her all the time for keeping her outside, one shoulder up. She was a sculler. He's like, get that thing down. So I looked at her. It's like, this thing is so jacked up that it can't come down. We, eliminated that, made it better, a treatment or two. She comes back. She's like, Cam's like, this is great. How did this thing come down, And it's really the fact that it couldn't before. So if you, instead of just barking and like, hey, maybe it can't function. And that's something for coaches to keep in mind. Like, just because you're telling them, it's not that the kid is not trying, it's that their system may not even allow it. So go see somebody, all right? And so go see Mark. Go do this. You need to address this issue. So something that small could change your mechanics. Okay. Again, serratus, one structure in here that I deal with all the time is called a long thoracic nerve, and this nerve supplies the serratus. Again, at this juncture, at the insertion of the serratus, particularly the 5th through 7th ribs, at that juncture of connection is where you see most of your rib fractures. This nerve gets inflamed and over-irritated with work, and oftentimes the reason serratus is weak is because it's spastic and dysfunctional, and this nerve is ticked. That nerve supplies the serratus. So what happens is that nerve's inflamed. It's telling this thing to shut down. Okay, you work without that shoulder blade being secure against the rib cage, and the nerve is inflamed and telling the system to shut down. It's just a matter of time before that gets to bone strain, and now you're having a rib issue. Okay, so the system itself is trying to protect itself, and in that process if you keep going, it's harming itself. Okay. So here we see a shoulder gird. This is really common. A classic right-hander, this is what you're going to see. And this shoulder blade is called winging, and it's going to wing away from the center of the spine, okay? And you can see compared to the opposite side, it just lifts off the rib cage. And what happens with that is that these structures, middle, lower trapezius, and the rhomboids, get stretched and weakened just by that position, okay? And oftentimes it's due to posterior shoulder tightness, tightness in the pec, tightness up in the neck, all right? So we have to relieve all those things to help get this back and then also loosen the serratus. When that person goes forward, if you're reaching out as a sculler, okay, or a sweep going to that opposite side, this whole thing's going to wing out, okay? And that's what's called scapular winging or dyskinesis. And that, again, the back of the shoulder is tight. These get attenuated, weakened, they attach to the ribs, and we got the beginning of a problem. Okay? So it's really relieving all these things. As they come up, their neck starts to overwork, upper trap, because that shoulder cannot elevate on its own, so the shoulder blade has to come out and make up the movement. Some docs will take a look and they go, oh, that's moving fine. This guy's fine. It's how is it moving, not that it's moving. Okay? And that you need a professional to kind of help discern all that. So these major muscles, what we found with screening juniors, screening elites, screening collegiate athletes, is that these two muscles, the middle trapezius and lower trapezius, are not working well. They're huge muscles. They pull that shoulder blade into the spine, directly inward and down and in. All right? And we find chronic weakness. There's not many rowers where I don't see this being weak, just due to their position, and it's yanking on that muscle. The muscles that take over are the upper trapezius, and what that does is elevate. Just like that guy elevated his shoulder with his neck, the rowers do the same thing. They're finding stability up here instead of down here. What we see with ultrasound is that the tears occur in the rhomboid because this muscle pulls up. Once these big guys aren't working, this little rhomboid is now doing all the load, and it's going to last for so long, and then it's going to have an issue. Once that goes, the winging gets worse, and now you've started the whole cycle. Okay, so that's going to be a major portion of our work, is trying to get normal position and function of the shoulder blade. All right, so if we look in the front, we got the big pec here, and the pec attaches to the ribs also. You see a lot of spasm up in the pec oftentimes with rib injury, but the pec pulls the ribs down and in, but it's dependent on shoulder position. And what I'll show you is that when there's a dysfunctional shoulder in a rower, their go-to is going to bring those elbows out to the side as they pull up, because they're going to use their neck and their rhomboid to do the work. That increases the amount of stress of the pec on the rib. They're anchoring here, and that again pulls up while you're going towards the finish, and the big abdominals are pulling down. All right, so it's a classic go-to, and this is where we want to address with our exercises. Also, too, you get these big, deep muscles down in here where you get this costochondritis, it's called. You know, it's inflammation of this tissue that's pulling the ribs into the chest wall. Now, or into the sternum. What happens here is that when you get a rib injury, all this tissue all around the inside the ribs gets swollen and restricted. That rib can now not bend, allow bend sideways, shear, okay, or rotation. And what occurs is that the motion now comes at the least, at the easiest point, which happens to be, one is in the front, which is where the cartilage meets the rib, okay, and two is in the back, where the rib meets the spine. So a lot of times chiropractors adjust this and you get all that stuff going. And what you find is that you need to address this tissue in here to allow that movement to occur, so that the optimal motion is not to pop out the front or the back of the rib. Okay, so even though there's, could be chiropractic manipulation, things of that nature, just understand that this thing works as a full circle, okay? So oftentimes these things are irritated, they just need to get calmed down. They can just be just as bad as a rib fracture in terms of coming back. Okay, in the back, again, we have muscles that serratus posterior inferior, serratus posterior superior, that also supports the ribs. You have your thoracic paraspinals, QL muscles from the pelvis coming up, all right, that also affect how rib function. So their spine better be moving. You got to have normal hip function, pelvic motion, all right, for the ribs to work optimally. It's a huge job. You need to manage these things. And the same with the thoracolumbar paraspinals that go like a hook and ladder, and they go all the way up connecting the neck to the pelvis. So anything along this line that's not working right, that affects the ribs. Okay, so it's huge. The amount of forces they take, the opposing forces, what's going on really needs to be appreciated and understand what an important structure they are. Looking at now, just what's a good position. Feet are flat, calves are loose. glutes loose, allowing easy slide into the catch. Everything's relaxed up in here, okay? And that's what you want to see, is that it's easy. It's like a drawer coming in and out. All these structures are allowing this normal position to occur quite effortlessly, okay? In guys, you have problems with this because of their growth, and their musculature doesn't allow it, typically down low, okay? A lot of women, the problem, again, is core strength, okay? Strength in the glutes, and also in the abdominal musculature to maintain an upright position in order to get to this nice-looking catch. Okay, so here we're just going to look at just two different styles, okay, and just which one had a rib injury. And you see, good old John here, he's just plugging right along, and his neck is quiet, he's blowing out, everything's moving downward, really pretty. Okay, how effective he is right now, I'm not sure, but it looks really good, so I filmed it. But here we had a gal with a rib stress fracture, and this is her before all this happened. And what we're seeing is just how high she's coming up. Okay, the elbows are coming out from the sides, using her pec, really not breathing with the effort that John was, and kind of getting that lean back. Her abdominals are really holding her up at the finish. Okay, and we looked at this, on the right side, and it was just totally congested and having issues when she first came, and had a rib fracture within the first month of being there at the elite camp. Okay, so if we look at it from the side, okay, and here we got John. It's a nice, smooth motion. Okay, neck is quiet, his shoulders are quiet, everything's driving from down low. Okay, coming right into this, into the belly. Okay, looks really sweet. Okay, now let's go here, and I'm just going to watch this, and right up, everything's going up. Okay, now she's working at a harder pace. Okay, but we'll just slow that down. Coming in, she's not getting, her heels are up, really bent over at the catch. Okay, head is up. All right, driving right from the neck and shoulders. Like, boom, coming right up. You do that enough, your shoulder blade and your rib cage are going to take a beating. Okay, going up further. Okay, elbows out to the side, the neck is forward, legs are done, she's coming back, and boom, you're getting this compression. So the ribs are compressing, the head is forward, everything is pulling up, and her abdominals are working way hard to keep her from falling backward. Okay, opposition of forces, okay, and where's the rib fracture? Pretty much right in line with where her forearms are. Okay, just follows right down there. Okay, so it's just something to consider. And again, just looking at the catch, head up, coming up, everything's up, and look at where she's finishing. It's right up around her throat. Okay, so it's, again, how are we doing this? And we worked on correcting this and getting her mobility back, and that looked pretty good. From behind, okay, here I just want to show you this because his muscles really show nice work. And again, here, neck is quiet, everything's pulling down and back, effort's going into the hips, pelvis, and legs. And you can see the muscles, his middle and lower trapezius really working. They stick right out when he pulls. Nice and even. Elbows are in the side. Okay, a lot less stress to the ribs. Now this gal, she's pretty fascinating. And what happened was she had a rib fracture before NCAAs, wound up resting, got through NCAAs, took time off, and then started sculling in the summertime without getting treated, and developed this glitch. And this is, again, this what she did to get around things. Now, this is huge, and a lot of times it's much more subtle than this. Again, look at what the elbow's doing. Okay, she's trying to find support in her neck and upper and her rhomboid. So you can see as she's going through, she hits the catch, coming up, elbows coming right up, shoulder blade. She's supporting with her neck and her rhomboid. shoulder blades coming right off the rib cage. Okay, as she comes up, she's not that strong there, so what does she do? She brings her elbow way out and using now the shoulder to do what the shoulder blade should be doing. Okay, and then coming back when the forces are less, and then just repeating the entire process. She got really good at this. So can she get through her workout? Absolutely. Is this the way to go? No, probably a rib will break within another month or so. So we kind of worked on her again. This is what that looks like. And then, working on restoring normalcy, and she really had to focus on trying to get this back down. In fact, this athlete never really got back to normal, and it affected the rest of her career. One mistake, one summer, just changed everything. As she got to rate and started in the boat, this would just start to come up more and more. Couldn't get rid of it, okay? So don't do that, okay? That's pretty much it. Don't be that person, okay? Here we got another one. This one's really fascinating. And, okay, what we have is just coming up, and you see how that shoulder's trying to find a stable point, okay, and it is not working well. And she has a tough time, but she's just trying to find stability. She wound up having a cervical disc issue, which I think came after her, shoulder dysfunction. She's just using her neck all the time, and you see this here. Okay, and just coming up, and again, as that she hooks in, she's not stable with her serratus, nor her mid or lower trap. The shoulder blade is coming way off away from the spine compared to the other side, and what does she do? She picks her arm up in order to get her shoulder involved. The neck is involved, and look at the angle of the erg handle. Okay, so oftentimes, I have them look at just the angle. Just focus on the angle of that and keep it level, and that may be helpful. Okay, big thing, screens. Screens are huge. I love screening. It tells me so much about the individual and the population. But I screened, about 30 Mercer kids, and for the heck of it, I just looked at the elites that came in for the last 2 years, age 16, age 22 average. Their scores are worse coming at the elite level, okay? We're looking at neck mobility, trunk mobility, posture, hip mobility is about the same. Hip strength significantly worse, okay, as they got older. Shoulder special tests, no big difference. Shoulder mobility, a little bit improved, and then shoulder strength's actually worse. And where the strength deficits are, the middle and lower trapezius, rotator cuff of the shoulder, right more than left. Almost like I'm talking 80 to 90% of the individuals that tested. Okay, so what does this tell me in general? We haven't taught them anything from 16 to 22. Also, too, that this is the tip of the sword. These are the guys that made the elite program. What's everybody else like? I'd love to see that, how that looks. So it's like, just realize we need to do more work in education, getting things to work appropriately, and make sure these athletes come out better than what they started in with. Okay. Chest wall pain, again, pain in the rib region, anywhere from sternum to spine. Okay, many reasons for chest wall pain. Again, from the bone, inflammation of the joints, thoracic disc, inflammation of where the rib meets the spine. Okay, all those things are points of problem, as well as the tissue. The tissue is like the easiest one. Let it rest, let it move, get it going, and that usually works. A lot of these costovertebral joints, a lot of times things recur because there's too much mobility in the joint. It keeps coming out all the time. So you have to restore mobility in the tissue around the rib, and sometimes support that utilizing medical means like PRP or prolotherapy, something along those lines. And that can be a bigger problem than the rib injury, okay? Just know, if they're talking to you and you just go, hey, what's your pain level at? 0 is nothing, 10, you got to go to the emergency room. And their best is 3, send them in. Like, don't even hesitate, okay? Go in. Also, 2, just looking at just the subjective questions. Pain with deep breathing, lying on your side, doing a sit-up or push-up, rowing or erging, upper body lifting exercises, prolonged sitting with poor posture, trunk rotation, twisting, side bending, or pain at night. If 4 out of these are positive, it's 85% chance that there's a rib injury. So just by talking to them, you hit 3 to 5 of those, and it's like, go get checked out. Okay, I'm not going to get too much into what the reasons for rib injury, but here we have Pac-Man, these osteoclasts. They actually eat bone under stress, okay, and then they're caught up by the osteoblasts, which are called Bob the Builders, and they require energy, proper hormones, vitamin D, and calcium. These guys kick in as soon as they're stressed to the rib. Okay, so 2 to 4 weeks of doing heavy load, heavy work, and you're breaking bone down. Okay, and it may take Bob the Builder a little longer to reproduce new bone. So at 2 to 4 weeks, you start getting a lag between that, and that's where a lot of times rib stress fractures occur. And also, too, if there's not enough nutrients to actually, produce new bone, such as vitamin D and calcium and appropriate rest and work, it can take longer. So to break down bone resorption phase takes like 2 to 4 weeks. Formation is 4 to 6 weeks. That means if you have a rib fracture, to fully formalize bone is going to take 4 to 6 months. What's the best option? Prevention. Don't let it happen, all right? That can be a pain for a long time after the injury, just to the metabolics of the area. And this is what it looks like when you have microfracture of inside the bone, that it's resorbing bone. The body resorbs bone inside the rib, and it starts to break it down. And after 2 to 3 weeks of breaking it down, and you put heavy load on that, this can break and start involving the cortical bone, the bone on outside, and that's where you see the fractures. Okay, so rib stress fracture, that's what it looks like on MRI. Again, it binds itself to the rib above and the rib below. To treat it, we'll oftentimes just splint that with tape in order to keep it immobile and less painful, which works really well. Okay, again, this is over time. Muscle fatigue, and this is a big one. If those muscles are not capable of really supporting the spine and the ribs, okay, the muscles are a load absorber. They absorb load. If that's serratus, if those abdominal muscles where they attach, if they're weak, that load goes to the insertion, and the insertion is the rib. And there you have it. The breakdown starts. Okay, so understand that feeling good, and that's why just doing simple. What is your perception of your fatigue? Having normal, just feeling good and being ready for your workout is so important. If you feel down and weak, that is going to affect your function and can actually start to lead to injury. Okay. And so the third week, again, if you load that bone for 2 to 3 weeks, this is where the bone is weakest. It's been eaten away, hasn't had the process of getting Bob the Builder to put new bone back, and now in that third week of heavy training, boom, you might see a propensity of that happening. So, modifying your training schedules to do that. Using ultrasound, this is very early in a fourth rib fracture. We can see that there's a deviation in the bone, no periosteal inflammation yet, and all it took was 4 days of more stress and a little bit of rowing, and boom, now we got it breaking through the periosteum, and we've got a rib issue. Okay, so we can see this right away on ultrasound and respond to it in treatment. Okay, we look at this 2 weeks later, and we already see callus formation, no break in the bone, but this is not normal bone, it's just forming. Okay, so we follow this. Once they have a rib fracture, we follow this every week, and where are you? How does that go with your symptoms? When we make a decision to go back, this at least has to be in play. Okay, when we make early decisions to get back early due to racing or something along those lines, it's by signs and symptoms, but also some objective data on how this looks. Okay, if that didn't look that good, you're not going back. Okay, we can also see on top of a rib fracture, tears in the rhomboid muscle, tears in the intercostal. So this might be more complicated due to tears in tissue surrounding the area, knowing what we have to deal with, what we have to strengthen up, and that we can see that with ultrasound. And that's what makes it such a beautiful thing. Okay, looking at that 6 months later, everything's healed up, looks good. We just did it at 6 months because, like, hey, let's take a look at this and see what that looks like. But I'm sure that happened a lot earlier. Okay, and if there's intercostal strain but no fracture, okay, so we can delineate that. We had a gal in selection. She got majorly upset. Oh my God, my rib, I broke my, this and that. In 5 minutes, we figured out it's just an intercostal strain. Within a week, she was back in the selection process. Okay, so the more the athlete knows, the more the coach knows, the more that we know, we can respond to this, look at it. Are you ready to go? We see it objectively, not just on signs, symptoms, and what the athlete is thinking at the time, because we know what they're thinking, they want to get back. Okay? Whole slew of, rib injury. What are the factors? Strength, huge one. Okay? If there's concurrent shoulder hypermobility injury, low back injury, previous rib injury, lightweight rower in females, it's just more prevalent on coming back. Reduced bone density, weight loss, relative energy deficiency in sport, diet poor in calcium and dairy, vitamin D deficiency. Those are nutritional things. That's why nutrition is so important, particularly in the light-weight population. And then just poor mechanics of rowing, okay? Again, as coaches looking at, higher, are they over-geared, high-geared, rowing at low rates for long periods? Strong winds, changing, any change, changing from large boats to small boats, vice versa, erging to rowing. Any transition increases the probability of having a rib injury, and just, over-geared rigging and just long, steady state rowing, particularly if they're not rowing well. Okay, so to remember, rib is just the victim. All right, it's really the musculoskeletal dysfunction around it is the perpetrator. Poor rib management is the assassin. All right, and if we don't manage that well, it's going down. That's it. It's not the rib, it's everyone around it. Okay. Okay, so I put together this rib prevention program. Basically, it's just really working on form and getting the shoulder blades to work, all right? You're going to just use small increments, and you probably have all these things in your boathouse or clinic or what have you. I just put down, if you're going to open these things, open it with Chrome or Adobe Reader so that it comes out right. Okay. Progress when all activities of the previous stage are pain-free, performed with appropriate control, speed, and endurance. Return to early stages. Restart the program if you've had an injury. Injury will shut down normal mechanics. You have to reteach it again. It may not take as long the next time, but you're going to have to reteach it. It's gotten used to getting around it. You have to kind of give it a reminder. Also, exercise is an adjunct, not a replacement for proper treatment. Can't tell you, I really fear sometimes giving exercises because people come back and they're like, I did all your exercise and they're still not better. It's like, have you sent them to somebody? It's like, no. Have we stopped rowing? No. So, it's just an adjunct. It's not the total thing. If you're having pain, please if that athlete's having pain, have them checked out. This is not, a means of cure. Okay, so the first stage is really restoring motion, okay, in the thoracic spine, scapular, shoulder mobility. Educate that client in that athlete in setting the shoulder blade, okay, into a down and back position, and minimize upper trapezius and neck firing. Relax the neck, move the shoulders. That's pretty much it, okay? And then we're just going to get more aggressive going against gravity and incorporating different body positions and things to do that as we go through the entire cycle. All right, and we want to, incorporate core, body position, movement, utilizing, the rowing motion also at the end. But also, when you see kids at a certain level and they're all just getting to this point, that's your limit. You also have to realize when you're training and they're only getting to like certain low stages of function, and I'm going to, bury them with some, long erg pieces and this and that they're going to fail in a short period of time. You're training dysfunction. Are you training? And that's the question. Am I training good function, good form, on my devices, or am I training dysfunction? Okay. I had a kid, at Mercer. I know this is going to occur at junior level. We train these Mercer kids. And the kid came up and said, I'm having some problems on the erg. So I was at the boathouse, got the coach, got the kid. We put her on the erg, and she's doing these funky things with her shoulder. I said, come with me. So took a look at her, loosened up her shoulder. Her entire right side was tight from her pelvis and hip up into her shoulder blade and neck. Took about 15 minutes, unleashed some of that. Got the coach, got the kid, back on the erg, boom, everything's looking good. All right? That's all it took. It's like, that's sports medicine working with coaching and athletics. Not to just treat injury, but keep it from happening, to perform with good function. Okay? That kid goes, if you kept that dysfunction going, there's no complaint of pain. If that was there for 2 to 3 months, you may have a problem after that. Okay? If we can get that resolved quickly, early, boom, we're back to good, let's get going. All right, so that's like the optimum of where I'd love to see everything in the future. So I'm going to go through just a couple of these. All right, just some neck stretches. Okay, and really just the scalenes are the muscles in the front of the neck. Okay, and you're going to see them pop right out here. Okay. And what that does, it allows that shoulder blade and first rib to descend, okay? So if that is really tight and she's, not able to descend that shoulder blade, the neck is oftentimes the first place you got to start. Allow that truss to relax and go down. Okay? And just tilting and going back. There you go. And get the scalene. You can see them pop right out of there. Okay, same thing with the upper trapezius. Okay, that's a big muscle in the back that is often overworked, so we're going to stretch this thing in order to make it happen. And this one on her is extremely tight. And good. So she grabs the back of the chair, just tilting away. And as she leans forward, you're going to see this muscle just pop right out the back. And you can just see it right in here. It's just sticking right out, and there you go. All right, so just stretching that. We do soft tissue work to loosen it, teach the athlete how to stretch it. Just by stretching alone, that's probably not going to reach normal length. Okay, first rib mobilization, just using a towel. Okay, put it around the first rib. And all these online are explained, so the reason that it's slow is because I'm talking through the whole thing, and I'll talk you right through it. So just put it around the nape of the neck, secure the first rib, bend the head away, and lean forward. And this is going to lower that first rib and the shoulder blade and the clavicle. Okay, it's just real simple. 10 reps, 10 times. Make that part of your practice. Mostly tight on the left in most right-handed individuals, just due to their normal daily lifestyle with computers and things of that nature. Okay, that's simple. All right, just, instead of foam rollers, I really like just using a tennis ball and really to mobilize the thoracic spine. That thoracic spine, we got to get them out of the hunch and get them up and back. And a simple way of doing that, okay, is to just use a tennis ball and just lie on it, put it at the spine where you feel the restriction, and just move the arm up and down, and that creates the force to mobilize the vertebrae. A lot of times the tissue's swollen because the vertebra is not sitting where it should, nor is it mobile, okay? And just lying down using a tennis ball. Watch out with foam rollers, things of that nature. Here's what happens. Tissue's irritable. You get on it, you rub it out with a foam roller or some lacrosse ball or some foreign object, and it sends off this pain message. Your body secretes pain-relieving endorphins and tryptophan and serotonin, and that cuts the pain down for about 15, 20 minutes. It's like, oh, that feels good. And then it's more inflamed, and it comes back again. So what do? You go back and do it again because it felt good. You do that for a day or two. This tissue is now so inflamed, it's going to take a week or two to calm down. So just be careful with how much you do things. And real simple, easy stuff is best. Athletes, particularly rowers, don't know the term what's too much, and that's where you got to cut it down. The back of the shoulder being tight. So this is really important, a nice way to just stretch that. Okay, just doing a sleeper stretch, and just have them pull that hand down. Body weight is securing the shoulder blade, and that's now a way to stretch the back of the shoulder. Okay, real simple stuff. You can do it after practice. Is a nice time because the tissue is hot and warm. Hot, warm tissue responds to stretch very well. All right, or coming off a bike warm up or cool down, this is a good time to do it. Okay. All right, nerve glides. I like nerve glides because they're gentle, they provide stretch, and what occurs is that rowers go, a lot of people stretch too harshly, they affect the nerve, and then what happens is they stretch, that nerve then sends a signal to tighten things up. I don't know if you ever had an athlete that's like, yeah, I stretch that all the time, but after I stretch, it actually feels tighter. It's like because the nerve is restricted somewhere down the line, and what we're doing here is affecting that, stretching that nerve from the neck all the way down to the fingertips. So they have forearm tightness, hand tightness. That nerve goes the entire length down. It's just a nice way. I just tell them, go to tension. That's it, tension. Not stretch, not this, just you feel tension. That's it. You can feel it anywhere from your fingertips to your neck, all right? It's a nerve. Do not tick nerves off. They will shut you down. Okay? Again, just simple cat and camel. You guys probably know that. Nice stretch is this one right here, just doing an active stretch. This is great, before or after practice. And just getting the arms out in front, incorporating the hips. Okay. And just reaching up and back, okay? Nice little stretch there. Okay. These are other things that you can look up, just yoga poses, all right? And again, just combining in upper body, lower body to this type of work. Okay, just getting the front of the chest, everything opened up. General rule, open up the front, close down and strengthen the back, period. All right? Okay. I like doing a lot of rotational things. This one here I like because you're limiting the motion of the lumbar spine, really affecting motion of the ribs, and just coming down and up. And you press your hips into the ball, and now rotate up, and it isolates motion up top. Okay, just incorporating these into your daily activities, warm up, cool down, what have you. Okay, these are great too, just doing some hip and shoulder openers, like just using a pullover. And again, you have all these, they're all, this is all, once you go online, we'll have this linked in, and it's all explained out for you. Okay, just doing a pullover. Okay, opening the shoulders, lats, okay, abdominals, hip flexors, everything's opening up. Great thing to do after practice. Okay, nice and easy. Okay, are part of their workout regimen, doing strength and flexibility things. And just, that's like a 5-pound weight. That's usually what I give them. That's plenty. It just helps the process. Okay. Yep, okay. So we're going to just work down. I just want to show you 2 concepts. Okay, one is just a plank, just doing a plank. And this is done from the going into a plus position. Okay, and then just coming up. And what you're doing is using the body weight to actually stretch the serratus. And you can see that the winging of the scapula, the serratus is stretching, using body weight to stretch it, and now tighten it and get the body through the shoulder blades. Okay, so you're working it and stretching it, working it and stretching it. Okay, and this can be done from forearm and knees position, and this is what I call a plus position. When they go up, so anything you see with a plus, that's what it entails. Just bringing the trunk through the shoulder blades. Shoulder blades are secure to the rib cage, and holding that. Pretty tough. Okay, just going to show you real quick. Just real easy, way of introducing these things, again, it's just having an athlete squeeze the shoulder blades down and back and just pulling apart. And you see all the musculature of the scapula working, you're setting it, and now reinforcing it with an isometric. This is where I start with everybody. Do they understand this concept of relaxing the neck, bringing the arms out? Okay, and squeezing the middle trap and the lower trapezius. And then we're just going to do that with different activities like a tricep extension. And then starting with a lat pull down, it's easier to do individually and then do it bilaterally. So what we want to do is to really engage, teaching engagement of the scapula. Okay, so coming right here, engage the scapula, start with that. Okay, and now pull. Bring the arm through and then finish with the scapula. And that's like how fast, and it's really hard to do. Okay, and for them not to elevate their neck, get away from combining the neck with the shoulder blade. Like all these things, that's their main purpose. Okay, engage, pull, and come down. All right, down and back, igniting that lower trapezius. Okay, you can use cords or cables, bands to stretch into that posterior position. Again, bilaterally or unilaterally. Okay, and have the cord pull you down into position. Okay, and then you're going to just work the muscle, let it work. Now stretch, pulling you down and back with the cords. Okay, and then working it. And immediately now going into work. So come in here. Okay, engage, scapula, pull, and now follow through and finish with the shoulder blade. That's 90% of it, all the way through. You can do it in a variety of positions. Okay, doing it on your back with a band. Okay, sucking those shoulder blades and having gravity help to bring the shoulder blades into the foam roll, keep the chin tucked. Low back into the foam roll as feedback, and now bringing the arms up overhead. Okay, you can do this standing also. We use a foam roll just standing behind your back, and just relearning how do you emphasize the shoulder blades, keep the chin tucked and quiet, and go through the motions. Okay, and just pulling through. All right, how does this work? All right, and just really simple basics. This is great like at the beginning of camp or the beginning of, novice year, learning how to do all this. Okay, doing the same thing now in a lunge position. Okay, pulling back in a lunge position. Doing it at the catch, okay, in a position. And here we have it really with the palms down now and not using the palms up. Palms up facilitates that rotation of the shoulder blades down and back. Now we have to teach it how to work with the palms down as in an oar or an erg handle. All right, engage, engage, pull through, do it first with a single arm and then work to double. And understand that same concept of neck relaxation, work in the middle of the shoulder, and pulling through with the shoulder. And then finally, taking all this, okay, you can also combine in rotator cuff stuff, which I'm not going to work on, but putting it through the erg. And now how does this work? Okay, and just having them follow the same principles through. Okay, and squeezing through, and now can you reproduce this on the erg? All right, and that's just the beginning of training, and then how do we break this stuff down? It's all in there. We're going to put it online on a link, so everything's talked out, so every slide that's there, if you open it, there's video to explain it, all right? So any quick questions or anything? Yep. Yep, and we're out of here. Yep, got it. Yeah, go ahead. Yep. Yep.
And as far as timing is concerned, there was a discussion about inhaling through the drive as being more advantageous.
I like exhaling through exertion. It's just classic. You're going to blow out, push everything down. Your abdominals are your support for your spine. You want that through the drive, okay? Inhale on recovery, get a breath, exhale through the drive, okay? Simple. Same thing with exercise, right? When you're going to, inhale as you recover, exhale as you pull up, okay? Protection. It's all about protection, okay? Does that help at all? Okay, one other question, anything? Yeah? Normal strength, normal range. They can handle, return to what? Erging or rowing? Okay. Normal strength, normal range. There's asymptomatic with regard to palpation and things of that nature, or minimal 0 to 1 discomfort. When I have them go through an entire erg progression, which I've listed on another slide that you'll have, another talk that you'll have, and I go by 5 minutes every other day, progress up, okay, depending on their symptoms, and then that once they're at 3 by 20 with no problem, you can get back in the boat, okay, and then start increasing intensity. So it's a long time. We got to get going. Yep, I know. We're done.